Dr. John Humm, thank you so much for coming here to the National Cancer Research Institute meeting, all the way from Sloan Kettering, New York. Just tell us what you're going to be speaking about at the conference. It's all about microenvironment, it's hypoxia, imaging, it's all about.
Well, one of my areas of interest is really using molecular imaging techniques in order to try to identify features of the microenvironment that can be seen non-invasively. Hypoxia is a particularly important prognosticator for treatment outcome, and if one could actually measure it using an imaging agent, and positron emission tomography allows us to actually take a hypoxia targeting agent to label it with fluorine 18 or some other PET tracer, and then enables us to actually visualize where the distribution of hypoxia in the tumor is.
Tell me why hypoxia is important, apart from the obvious one, which is radiotherapy.
Yes, it actually turns out that some surgeons have found that even after operations where tumors are removed, when they have done prior measurements with a probe that can actually measure the level, Eppendorf probe can measure the fraction of tumor hypoxia in tumors, they found that the outcome is poorer even after surgical resection. This means that obviously there must have been some metastasis that had occurred, and that somehow hypoxia is some measure of bad actors, tumor cells that actually are more likely to metastasize.
Are you targeting stromal cells? You're talking about microenvironment. What exactly is microenvironment in your definition?
Basically what happens as the tumor grows, it outgrows the blood supply. This leads to gradients of partial oxygen pressure from the tumor vasculature into the center of the tumor. And by using different probes, one can see they actually target and lodge in areas of lower PO2. So one can actually see where these areas of poor oxygen diffusion occur.
So extracellular then?
So it's extracellular, and it's actually a location at a certain distance from the blood vessels. We know that those cells are resistant to radiation oncology, but we also know that cells under those aggressive conditions tend to be more metastatically able. So it's those cells that we would like to actually target by radiation therapy, and also to know that they exist, because then we know that might give us an indication as to whether the patient should have additional therapies such as chemotherapy.
So could you examine the lymph nodes in a patient with breast cancer using this technology?
Certainly we could, yes. We're looking at the moment primarily at head and neck cancers, and certainly some of those patients already have metastatic disease to lymph nodes, so we're also looking for hypoxia in lymph nodes too.
Mm-hmm. And targeted therapy with which depend on HIF and that sort of downstream factor.
Exactly.
Is that a possibility or not?
Yes, we also have a molecular reporter system that actually enables tracers to only be entrapped when the HIF regulatory machinery is turned on. So we actually have in animal model systems transfected cells so that they actually express either a fluorescent marker or they'll selectively entrap a PET probe as soon as they become hypoxic.
You talked about labeling with fluorine. Are there any other labels that you could use?
Yes, we're looking at other PET tracers too that have a longer life. One of the disadvantages of fluorine 18 is it only has 110 minutes. And agents have to actually diffuse into the cancer and diffuse into these areas of low oxygen pressure. That takes time. So there would be an advantage of using isotopes which have a longer half-life. Two others that we've explored is copper-64, which has a 12-hour half-life, and iodine-124, which has a 4-day half-life. And these are both also positron-emitting isotopes too.
Can you use this sort of technology to monitor antiangiogenesis treatments or that sort of thing?
Yes, that is an area that we're actually also actively involved in. We're looking at how, after an anti-angiogenic agent, how the actual hypoxia changes. And this can be done non-invasively. You give the tracer prior to the treatment and then post-treatment, and you look at the change, you study the difference in the distribution of the hypoxia selective tracer.
And it's all no touch?
And it's all no touch, yes, other than an injection into the patient, just a simple injection of the tracer. So this is one of the advantages. You don't have to push PO2 probes, such as these Eppendorf electrodes, into the tumour, which is an invasive, and so, of course, many cancers you don't even have accessibility of these probes.
Thank you very much indeed. I really appreciate it. Look forward to your talk tomorrow.